a number of years now of practicing it. So I guess Alan's outline of the sort of services and empirical situation is a perfect, I guess, platform actually for me to come in and say social sciencey things that are a little bit more kind of system level. So acknowledging that that we're coming from sort of different sort of positionalities, I guess, but actually I think what we'll get to at the end of this discussion is to think critically about both sides or both areas, both social science and infectious diseases, and perhaps have an interesting melding of those perspectives as well. So my, just to give an introduction to what we have been doing is largely focused on how practice is inflected by systemic kind of structures and priorities. And at the last minute, I inserted some brackets. We like to do that as social scientists in my title, where really I'm talking about intersecting influences in hospitals, actually. And it just happens that they also shape the context of AMR and antimicrobial stewardship in important ways. So that's really, I guess, the approach that I'm going to take in the next sort of 20 minutes is how we can think about the value of practice and practice change, but also the limits of that in the face of systemic economic, political priority setting, which we can't necessarily change. So some of this discussion, I mean, it's probably actually emergent from over a decade now of social science work on AMR and antimicrobial stewardship, but it particularly engages with a couple of papers that we've recently published, Mark included and Katie as well, one of which is the sort of the modern hospital executive micro improvements and the rise of antimicrobial resistance, which looks at an institutional level, essentially how executive makes sense of the requirement to improve, but the lack of resources to do so. And then linking to our recent paper, The Administration of Harm, from Unintended Consequences to Harm by Design, to take a more active look at how the way in which societies and economies and health services are organized is actually quite deliberate in some respects, and how policies are set to achieve particular things, even though they might be represented as perhaps wanting to achieve other things, one of which might be, is it to solve AMR, or is it actually to engage in good governance that ultimately reaches or addresses the KPIs of today or this year or next year versus the next, say, 30, 40, 50 years and beyond? So this leads me to an annoying but also very useful approach, which is, what are we really talking about? Like, what is the problem that we're trying to address today? Is the problem out of control antibiotic use in hospitals? I've done this also slightly annoying thing of answering my own questions in italics. And the answer, in my view, is no. It's not out of control antibiotic use in hospitals. In fact, hospitals are generally quite well governed. Is it out of control community antimicrobial use? It's not great, but it's also really not core to the problem. Is it poor priority setting as a species, as societies, as economies? Probably. Is it poor governance, the market economy, and short-termism? 100%. Now, what we tend to, or how we tend to view things, is the sort of the context, and I'll put a note there down the bottom, which just gives more weight to what Alan was saying anyway, which is ultimately in Europe, for example, between 2011 and 2020, yes, there was some improvement. It wasn't that significant. And in some respects, things actually got worse. So in the context of AMR, in the context of antimicrobial use, that's a bit oversimplifying the situation, but essentially major change wasn't evident as a result of a whole lot of initiatives, including antimicrobial stewardship. So that leads me to the next question, well, it should be another question, but I'll put this slide first, which is what is currently being done, and again, engages with what Alan described, although he may very well challenge some of the ways that I'm representing it, which will be absolutely interesting for our discussion post this talk, is ultimately the model that's been done in the context of institutions in Australia and beyond, and also a model that's been pushed for low and middle income countries increasingly as well, is this sort of trifecta of restriction, surveillance, and correction. Now, on one level, that is a completely appropriate and logical within institution approach, because ultimately what it says is we've got, I guess, the sort of, we need to rationalize and improve our practice, and therefore these are some of the mechanisms by which you can achieve that. However, very often it doesn't result in the kind of radical change that we need or want. And it's therefore surprising, or at least for some people it's surprising. So I guess we can ask that question as well, and I guess that's one of the ones that I'm going to try and answer today in a short talk, is why is radical change not happening when we are embarking, or we are on this slide towards an AMR kind of emergency? Now, among many, many other dynamics, three issues that we are confronting as social scientists in our work within the health services, but also beyond, is issues of temporality and accountability, and how that limits what we can and can't do. Issues around the market economy, how that manifests in health services, how we value and cost things, and the accompanying issue of cascading vulnerability, which puts additional pressure on practice. So this is what I'm going to try and kind of unpack a little bit through some qualitative data with hospital executives from an ARC linkage grant, again, which Mark and Katie are involved in as well. The basis of what I'm going to describe is that we shouldn't actually expect radical change. In fact, Australian hospitals are satellites within a system and are largely well governed. That would be my answer to how do we govern in hospitals? Well, we actually govern pretty effectively. The issue is, in many respects, the structural priorities and how lines of accountability are implemented and structured, and systems of exchange across institutions and within institutions. And my particular concern is how we price, how we cost, and how we value in these institutions. And the lack of appetite, in my view, for radical change, and therefore the worrying default to box ticking in some contexts, not all, is a product of structural problems, not of lack of willingness or will from those who are actually providing care. I want to give you some interview excerpts from some of the hospital executives that took part in our ARC study, and I'll read them out. So obviously, from a budget point of view, there's a huge cost associated with us ultimately not managing resistant infections in patients appropriately, and having to use more and more expensive drugs, but we don't directly measure anything around AMR. So it's not front and center of any conversation, I guess, whether it's an immediate measurable good. So antimicrobial stewardship is due to the good that it does at the time. That's kind of where it feels like for me. I don't feel like there's something that I could do that would significantly move the dial enough on the dollars for me to be able to measure it and say, actually, I've saved 1 million this year because we've done this. And I actually see on my balance sheet at the end of the financial year, because it's generally is hidden up and rolled up all together with other medication costs, and our systems aren't good enough to pick it up. And that is a very nice end to that quote, because what that is essentially saying is this is the rules of the game that I'm playing, and they are not valuing or costing this practice effectively within that system. Therefore, I can't actually prioritize it. That is what that hospital executive is saying. Then we have the political aspects of this process as well. So an executive says it depends where we're at in the election cycle leading up to an election. It's all about KPIs and meeting patient throughput and not having any media attention around. So at any cost. Once the election's over, the focus is primarily on budget. So we change what's important. Maybe we don't speak about it. That's what we do. We change what's important depending on where we are in the election cycle. And so my job is bridging that reality, politics with the clinicians who their focus is primarily on the patient. Now this dynamic, people will say, oh yeah, we know that. That's always the case with government. But in fact, that type of precarity of prioritization and the potential to deprioritize on a whim based on temporal kind of considerations, actually, A, you can address that by not allowing it to change, and B, it needs to be acknowledged in forms of success or failure that that indeed was a factor within the outcome that we're looking at, as opposed to why can't we improve systems? So the issue of box ticking, again, is an issue of politics. The State Ministry of Health, their interest in antimicrobial stewardship would be minimising the extent to which it costs them money and maximising the extent to which it saves them money, making sure they at least appear to be paying paper and lip service to what is required of them by appropriate concessive documents and statements. None of them at any high-level management in the hospital ever talks to me about antimicrobial stewardship. It's just not something that any of them are interested in. And that's probably because we have our AMS committee, we have our AMS rounds, we have our guidance system. I think there's definitely an attitude within the hospital that that problem has been ticked, and the box has a big tick sitting on it. That is a hard quote to read. So what is that telling us? It's not telling us the systems don't work. It's telling us that the ideology of the service is about performativity of success and types of accountability, largely to do with optics in this context, rather than reduction of infection. In fact, if you fail to reduce infections, it's not costed, and therefore there's no blowback on you as an executive anyway. So if you can see, or we often focus on the practitioners, but if you actually focus on those who structure delivery of care, you can see different forms of power, influence, and feedback loops affecting what they will or won't support. This is another interesting dynamic around the public good and AMR, or antimicrobial stewardship, as well. We can see where we're going, but there's no will to make a change. So I feel like antimicrobial resistance sits in that basket of, I don't quite know what you need to do to be able to make the public understand that this is important, and therefore drive our political masses to do something. So this is connecting the loop. They're trying to make sense of why the politicians and the ministry won't take seriously something they need to do, and therefore create lines of accountability, therefore they can take action. So they're sort of creating some interesting observations around the kind of interesting kind of connectivities between spheres. Because our political masses, the way they work in the media cycle, they won't bite off anything unless they feel like there's votes. So I do believe that I have a responsibility to do this, and I'm very comfortable with having programs that support antimicrobial stewardship and all that sort of stuff. I think they're really good, and I'm quite happy to resource them, and I think ultimately there's probably some dollars to save from doing that, but generally it's the right thing, and so quite happy to do it. I guess the way we try and work here, and certainly my management philosophy is, I see it as there's core things that are within my value set that I'll support, and antimicrobial stewardship to a point is within that. So I think what we're seeing there is a reflection on, I really want to do it, and I want to do it well, but I don't necessarily feel empowered to. That's the reflection there, among other more perhaps malevolent reflections on how publics are implicated in the mobilization of politicians, and that feeds through to institutions. So all of this kind of political, economic context at a practice level, at an everyday level, leads essentially to cascading vulnerability. Because what you're going to get is overlaying, so it's a paradox here, right? It's what we call in one paper, the fetish of antibiotics, which is when you get, in this context, an economic and political system which is unable to take a long-term view and invest appropriately in what is going to be, I would imagine, the problem of the next few decades, if indeed the virus ever diminishes in its significance. And ultimately, what happens on the ground is the kind of emergent vulnerability of increased pan resistance and increased morbidity and mortality within the hospital sector is an increasing reflex to use antimicrobials as a salve overlaying what I would call political context, which is unable to address the kind of slow burn issues, although it's not really a slow burn issue anymore, it's accelerating. So my final notes, and I was going to write conclusion, I thought that's ridiculous because it's really only the start of the conversation. My reflections, and Alan will most likely have different opinions on this, stewardship ultimately tweaks within systems. And so what that says to me in all of our observations is that neither hospitals or antimicrobial stewardship is actually the problem. And neither is it the case that AMR is impossible to resolve, and nor is it the case that new antimicrobials are impossible to produce. It's not a discovery issue, and so forth. Actually, it's largely, if one takes a more panoramic view of the problem, the hospital is sort of assembled by a set of enduring and often malevolent structural priorities, which ultimately assemble the problem. And we are distracted by, to an extent, and we started off, I think, pre the recording, Mark, talking about the politics and practices of distraction, is that we risk being distracted by elaborate systems of practice change when that puts all of the emphasis and responsibility on clinicians, when essentially the game is set to work against the very thing which it is trying to address. And so that leads me to say, well, and I started writing this slide thinking, I'll write about how we're going to change the system. And I thought, no, that's too late in the afternoon for that. Let's talk about, if we aren't changing the system, what should we do? In the current model and set of parameters that we're given, what should we do better? And so then I thought it would be a more, well, is it less ambitious or more ambitious? I'm not sure, you choose, is to actually think carefully about how we, in a very fine-grained manner within systems, cost and value practices of improvement, but also, reimburse essentially improvement in a very holistic way in terms of how I would think about improvement, that we come up with better models of supporting diverse modes of stewardship. And the reality is that, Alan noted the accreditation requirements, which are essentially minimum standards. And that is excellent to have minimum standards across all health services in Australia. But again, that is a starting point as opposed to something that will, in the words of one of our executives, move the dial, either in terms of AMR or in terms of creating better environments and hospitals which have more appropriate use of antimicrobials, lower levels of resistant organisms and so forth. So given the fact that most of what I have said is reflecting on the economic and political parameters which shape practice and how they create headwinds for AMR And antimicrobial stewardship is always, in a lot of contexts, has a marketing problem because it's considered to be, or it doesn't have the pull of various other improvement or technical kind of influences in medicine. It's ultimately much like infection prevention and control, although this is a bit outdated, me saying this now, because I think that has really had its 2+ years in the sun, has not necessarily been a major investment from a health service perspective, or not seen as a priority in the same way. That's changed to an extent. So, and I think that leads us to the final very difficult question that a lot of those working in AMR internationally who are health economists are interested in exploring, which is, well, if we mobilize public sentiment and we are successful in that regard, how can we sort of prime publics, and this is edging towards work which clearly Mark is more expert in than me, to actually support investment and ensuring that those costs are able to be paid and that they don't come at too much of a political cost. And what that, in my view, will do by establishing better conditions to understand the value of what the many different people in the context of AMR, what they're doing, including antimicrobial stewardship, is that that will indeed feed through to drug development priorities, insurance premium potential increases with flows through to reimbursement for health services. There is an entire assemblage of economic cost, value, and reimbursement in the context of AMR that is not united, that is not mobilized around a cause, that is reactive, and that ultimately is temporarily fragmented, which means it can't actually make much of a difference. And there's the pills rotating around again.
That